Your Health Matters. I'm Pat Williams, along with Dr. Benjamin Bryant, Chief of Staff and Chief General Surgeon here at Conneaut Medical Center. Doctor, how was the holiday?
Well, you know, when I left, I went down to Virginia, actually, Pat, to see my twin granddaughters. And when I left, there was all this snow on the ground, and when I came back, it was all gone.
It went away in one day, I think, 1 or 2 days. It got so warm. It was almost 70 degrees Monday, I think it was.
That must have set a record.
It was a record.
Wow.
So
it seems like it's cooling off now. So
they say next week we could be in for a good storm. So
here
we go again.
Here we go again.
I see we have a guest with us today.
Well, this is a great occasion for us here on this show to be able to introduce Dr. Maroun Matta, who is a pulmonologist and critical care doctor. His coming to our town is very significant and has created a great deal of excitement here in the hospital. And Dr. Matta, let me just say right up front how glad we are to have you here.
I'm happy to be here too, thank you.
What is a pulmonologist?
So pulmonary basically means the lungs.
The lungs.
So any person who has a trouble with breathing, who has a chronic cough, sometimes who has a chest pain that's not necessarily coming from the heart. Those are the patients that usually come into our clinic to be evaluated.
I see. And you had to take special training to be a pulmonologist.
I did. So I did my internal medicine residency, and I did that at Case Western University Hospital.
Okay.
And then I had to do an extra 3 years of specialty training in pulmonary.
On top of residency, an extra 3 years?
Yes.
Whoa.
And that was a joint training between pulmonary, which is the lungs, and I also do critical care, which is the intensive care unit. When people get really sick, they get referred to a higher level of care where it's the ICU, and I see patients with that setting as well.
Did you always want to be a pulmonologist? I mean, was that what you started out to be?
So I loved critical care first. I love the ICU first. I love how complex the patients are, the level of detail and attention to everything that's going on, the continuous monitoring that you do for those people. This was my first attraction.
Okay.
But then I started learning more about pulmonary as well, and all the diseases and the physiology and how the lungs work and all the problems that can happen with that, and that only made me like it more.
Excellent. Excellent.
That is quite significant, folks, for our ICU. To have somebody with this level of training helping to take care of patients, that's really going to expand our capabilities here in the hospital. You think that's true, don't you?
So we started November 15th, and since then I've noticed that we were able to keep at least a few more patients that we weren't able to take care of before, that we would have had to transfer, that we were able to keep and take care of in here and save them the trouble of being transferred to another hospital, meeting any other team and everything else.
Which is huge for our public. To be able to stay local rather than being transferred is a real benefit to the town.
Are you based here in Conneaut, or do you work in Geneva, or?
So I spend most of my time in Conneaut. So I am in Conneaut on Monday all day, Tuesday all day, Wednesdays in the afternoon, Thursday all day. Wednesday morning I'm in Geneva. I have a pulmonary clinic in Geneva on Wednesday morning. And on Fridays I'm at the main campus in Cleveland.
That's excellent. This is a very big plus for the Conneaut.
It's a huge coup for Conneaut.
Wow.
Yeah. Wow. So you also deal with lung cancer too, don't you?
Oh, we do a lot. We do see a lot of patients who smoke who are high risk of developing lung cancer. So we recommend the appropriate screening, and sometimes they come in with symptoms. If they're having a cough that's bringing up blood, if they're having some chest pain, if they're having some symptoms that would suggest that they're losing weight over time, if they're feeling really ill, all those kind of point us in that direction. So we order the appropriate testing, which is usually a CAT scan, a fancy x-ray of the chest. And then we do the appropriate biopsies if needed and the appropriate staging if need be, and then we refer them for treatment if that ends up being the case.
I see. So last spring, Dr. Argoti Green from Geauga was on, thoracic surgery was on, and he was very excited about you coming too. Obviously, because what that means is that I think what it's going to translate to, now you jump in here because you're the one who knows about this, but I think what that's going to translate to, our public I'm not sure if it's higher risk than the general public for lung cancer, but a lot of people in our community smoke. A lot of people in our community smoke, and we've had, toxic exposures over the years. There's asbestos issues, there's other toxic aerosols that have been associated with the industry and so on. So it's our sense that we have a public that is at risk for lung cancer. And the sense that I get from all this is that your coming here will probably translate to people being diagnosed earlier than they would have been otherwise. Is that a reasonable thing to way to look at it?
So that's what we hope. In the current time, in the current era, that we have CAT scans that were able to detect lung cancer at earlier stages, so they would be amenable to surgery, where we can take them out and have a cure for the patient. That's the hope for the age that we live in. And like you said, smoking is a huge risk factor. If you never smoked, you have about 1% chance in your lifetime, and that goes to about 20 times higher if you smoke. Asbestos only comes in to make it even worse. They work together and make it even worse than each one apart.
Okay.
And when you stop smoking, the effect of smoking doesn't go away right away. It takes on average about 15 years for that risk to go back to close to normal. Not necessarily to absolutely what is normal, but to close to being in that range. So that's why for everybody who's over the age of 55, who have smoked either 1 pack for 30 years or 2 packs for 15 years, and who have stopped less than 15 years ago, we recommend at least to start screening for lung cancer. Because those are the people who are the highest risk. And we do that, like we said, with the CAT scan. Depending on what we see, we may need to repeat that. If we find something that we need to take out, then that would be the surgery that we talked about. The key thing is those people don't have any symptoms. So this is screening by definition is for someone who's not having symptoms. So that's anybody. Even if they're not feeling short of breath, even if they're not having any chest pain, even if they're not having any symptoms, that's where we screen them before those symptoms occur, because at that time we would be at more advanced stage, and then we would have less options to treat them with.
This is really, really important, obviously really important. Lung cancer is a notoriously bad actor once it gets to a certain point, very difficult to treat and difficult to cure. But like so many other things, if it's caught early, it's curable. It's absolutely curable. So you've already sort of gone over who should be screened, but maybe we can go into that just a little bit more, because I think it would be a real benefit to the public to know about this.
Doc, can I ask a question?
Oh, please, anytime, jump in.
When I bought a house years ago, probably 30 years ago, there was a thing in the contract that they had to clean the house of asbestos. And apparently that was used as an insulation back in the day.
Oh, yeah.
Unheard of now.
Well, yeah, I mean, you can't do it now. You can't use it now.
I didn't realize it was that dangerous until I read that contract, and it had to be definitely cleared out.
Oh, yeah.
Or the deal wouldn't have gone through.
Right.
So it is a dangerous.
It's a greatly dangerous, and like you said, we learned about this just like smoking a while after it was available. It's a good option for manufacturer because it's heat resistant and it's not expensive, so they can use it to make benefit. But the effect that we've seen over time is lung cancer is the biggest, but there are other styles. So you can have fibrosis of the lungs, like the tissue of the lungs that's normal becomes replaced by elastic tissue that doesn't help you breathe. And the last thing that happens with that too is a cancer of the pleural space, that sac that sits around the lungs, that's called mesothelioma.
Yes, yeah, they have ads on television.
This is
Steve McQueen.
Yes, yes. Wow.
So yeah, there's a lot of stuff. Well, lung cancer is one of them that can happen because of asbestos in the lungs.
I had a buddy that was a fireman for many, many years and died of that because I guess the gear that he put on his head had asbestos in it back in the 50s,
before
60s.
anybody knew.
Yeah, it's amazing. I'm glad we brought that up.
The key thing about those is you don't see the effect when you're first exposed. Those effects can be about 30 years out.
Ooh.
So in the first few years when you're exposed, really nothing happens, but 10, 20, 30, up to 30 years out of your exposure to that asbestos is when all those complications start to happen.
Wow. Okay.
So the public, people out there are hearing this, and I mean, what do they do? If they're concerned, I mean, people are thinking, gosh, you know, I may have an increase for lung cancer. I'm not really sure about my smoking history. I know I smoked. I don't know if it qualifies. I've been exposed to a lot of secondhand smoke, you know, that kind of thing. And so how should they proceed? I mean, should they talk to their primary care physician and say, should I go see Dr. Matta? Can they call your office directly? I guess the thing that I'm getting to is that I don't think it's necessarily a job for somebody sitting out there to figure out, you know, if they need to be screened or this and that. What they can do is they can come and talk to you, right? And then you can go through the whole history and examine them and so on, and you can tell them the sort of risk that they have, and then you can take it from there in terms of whether, you know, to get a CT scan, to do a pulmonary function test, that kind of thing, so that you can really sort of guide them through this process. I mean, that's really the idea, isn't it?
It is. So I think the simplest thing is anybody, if you're over the age of 55 and you have smoked in the last 15 years, then you should definitely ask about screening for lung cancer. And it doesn't necessarily mean that everybody needs to be screened, but that's a question that needs to be brought up. It can be brought up with a primary care physician, but often they're not comfortable with how to do it, how often to do that follow-up, what to do with the results, so they often defer to a pulmonary clinic to be for the evaluation.
You see, and that's the whole point. I mean, that's the whole point, is having that level of expertise available to you, so that, you know, there's no guesswork, there's no uncertainty about it. You're talking with a specialist who knows this part of medicine. That's what he does, and I think it's important. I think it's important for everybody listening to realize, you know, you may be at risk for lung cancer. It can be found early. You can be cured. So this is just another one of those empowerment things that we talk about on this show so much, is empowering people to take the initiative to just go and ask the questions. You know, you can call Dr. Matta's office directly. I mean, you can talk to your primary care doctor. That's perfectly fine. You can talk to Dr. Matta's office directly, and when you come in, you'll have all the questions answered. He'll go through the whole history, and he'll go through all the protocols and so on, and then you'll know. Then you'll have an answer, and you'll be able to say, okay, I know where I'm at, I know what's necessary, I know what to do next, that kind of thing.
Absolutely.
You know, Doc, you mentioned something that I always was curious about too, secondhand smoke. And you hear more and more now about how dangerous that can be to a non-smoker or a person that's not around it. It can actually do damage?
It can do a lot of damage.
Really?
Yeah, so they initially started seeing those in two situations where they're most common. Before there was restriction on smoking on airplanes, the people who used to be on airplanes all the time, like the pilots and the people who work on the plane, they were the highest risk of developing lung disease and sometimes lung cancer. And people who work in bars, because there were closed spaces and everybody was smoking, so the amount of smoke was really bad.
Mm-hmm.
The other damage that happens from secondhand smoking is mostly related to the airways and in people with asthma and people with such sort of lung diseases to start with.
Mm-hmm.
Those are the ones who would suffer the most from being exposed to secondhand smoking.
It's amazing. What was it, Doc, 10 years ago when they put into effect that you cannot smoke in public in bars, like Doc said, it used to be terrible.
Oh, yeah.
In bars when
Sure.
smoke. And when we go to the casino sometimes, they allow to smoke in Pennsylvania, and boy, it's a big difference, you know, compared to where you go into a bar now or a restaurant. There's no such thing as smoke.
That's right. That's right. Yeah, it used to be in restaurants too.
Yeah.
And then they tried smoking and non-smoking section.
Right.
And then they finally said, no.
Yeah.
It became a public health issue.
Yeah.
Yeah, when they first started, the tobacco industry was so strong that they were putting all this push against putting any limitations, and eventually everybody knew that this is a horrible thing, but when they first started, people didn't know. So often the people we see in our clinic who are over the age of 60 and 70, and when we ask about smoking, they say, like, nobody knew, everybody was smoking.
Sure.
And so
Mhm.
it seemed like the cool thing to do. It seemed nobody knew that this was the effects, and it's addictive. So once you get hooked up on it, it's really hard to quit. And
It is hard to quit.
it's not easy, because the people who are able to quit are people who have tried 4, 5, 6 times before they actually succeeded. So people think that if they try once, if they can't make it, then and then they relapse and start smoking again, then they can't, but that's not true. The people who are actually able to quit are people who have tried 4, 5, or 6 times and failed before they succeeded on their last attempt.
I think it was the early 60s. I remember this as a young kid when it came out that smoking was not good for your health. And I remember my dad used to smoke Viceroys, and he quit immediately. He listened to them, and he lived quite a long time afterwards from just quitting smoking.
That's
you know.
fantastic.
But yeah, I remember that. So we've basically known, we're stupid if we smoke, but we've known for over 50-some years that it's not good for you.
Yeah.
And yet, like you say, it continues.
Well, it's tough. It's tough.
It's very
I
hard.
mean, to quit smoking is one of the more difficult things that there is.
Mm-hmm.
It's really, it's very insidious. It's very tough.
It's like an addiction, really.
Oh, it is an addiction, but it's not impossible. I mean, you know, hundreds of thousands of people have quit. Millions of people have quit.
Mm-hmm.
So it is doable.
Sure.
And there are things that, now I know that this question comes up, so we'll have you address it if you would. Are electronic cigarettes safe?
So that's a question that we get probably asked more often than any other questions in clinic, more in Cleveland, here, everywhere else. And the answer is, we don't know, because they're just new. And like I said, when people started smoking, it took about 50 years before we realized all the bad effects. Now with electronic smoking, are we doing the same mistake? And we wait about 50 years before we learn all the bad stuff that can happen. So that's a simple answer. Now what it's being advertised as, the nicotine itself inside the smoking, it doesn't cause cancer. It's all the other stuff that are added to it to make it slowly burn and give it that enjoyable warm feeling. That's what the carcinogens come from. Those are the materials that cause cancer. And the claim is that in that electronic cigarette, those are not there. They are there. When they tested them, they are there. At much less quantities than in the regular cigarettes, but they are there.
Oh, they are there.
They are there. When they tested all the materials that they looked for, they are present. In minimal quantities, much less than the regular cigarette, but they are there. So the question is, would we, 30, 40 years from now, look back and say, like, oh, we made the same mistake using the electronic cigarette? It does help some people quit smoking, but
That would be the issue.
that would be the problem. And
If
it does
you-
help people, but
If
then
people
they
would
relapse.
use it, oh, and then they relapse?
And then they relapse. They do that for a little bit, and they're able to stop the regular smoking, but then after that, a few months later, then a lot of them go back to the regular smoking after that. So it's not the magic cure. This is not the answer.
Is there nicotine in those electronic cigarettes?
There can be.
Really?
That's kind of
There
the
can
point,
be- there
because
can
that's
be.
what's addictive.
Yes. Yeah. Because I always thought it was just steam. You know?
So some of them can help with steam, some of them can have the nicotine in them, and the concern with those as well is you can put anything inside them.
Oh.
So anything that can be vaporized, and for young people who are starting to do that, there's a risk of putting some stuff that they shouldn't, and there's a lot of concerns that come with it, and so this is not what we're hoping for people to quit smoking. There are medications, there are patches, there is a lot of counseling, but the hardest part is the counseling, and we often do that in clinic. We spend enough time chatting with people. The addiction from the cigarette comes because you associate it with so many things. You wake up in the morning, you have your cup of coffee, you're used to having your cigarette in hand. You're watching the football game on Sunday and you're having a beer in hand, you're used to having a cigarette in hand. You hang out with other people who smoke. So there are a lot of challenges when you're put in situations that pushes you to smoke, and this is where we find the most benefit, is to talk to people about those situations and to have a plan. And to say, like, in the morning, instead of having a cigarette, I'm gonna walk for 10 minutes and then have my cup of coffee, or I'm gonna have my cup of coffee and have a fruit, or have a biscuit, or whatever replacement to that habit that you're used to having.
Mhm.
Something enjoyable,
Something that you enjoy.
something
Absolutely.
people will like, and they say, oh, okay, well, I don't have to just go without, I can have this.
Absolutely.
And
Right.
having this is much better than having this.
Right.
Absolutely.
I got to ask you, a lot of people in my era of the 60s smoked marijuana. Did not smoke cigarettes, but they smoked a lot of marijuana.
That was the 60s.
Yeah? That would be just as dangerous, would it not?
So there are some side effects to marijuana, and the concern now with these days, there is synthetic marijuana. And they try to synthesize that in a way that makes it last a little bit longer, have a higher impact effect, and those are even horrible. Those can cause renal failure, they can cause muscle breakdown, they can cause, like I said, a lot of damage to the kidneys and everything else, and we've seen some severe cases in the intensive care unit from
Whoa.
people who do those synthetic marijuana.
People,
So,
we are being warned.
Yeah.
Being
Yeah,
born.
so if you're offered that,
Don't
pass.
do it.
Pass. Say no, thank you.
Well, you know, that's a whole other subject. There's a big push for legalization and so on.
Right.
And recreational legalization.
Right.
And so on. And maybe we can devote another show to that.
Yeah, I
because
think we
that's a
should.
very complex issue.
It is.
There are certainly some benefits to certain kinds of patients from certain kinds of chemicals that occur in marijuana, not necessarily smoking it, but other things. But also, more and more negative effects are being uncovered. Negative effects in the central nervous system, you know, deposition of certain chemicals in the membranes of the brain cells that stay there for years. I mean, it's really Russian roulette.
It's complex, it really is.
So we can, but I guess one of the things that I'm picking up here is that if people are really looking for help quitting smoking, your office may not be a bad place to come. I mean, this is something that you do.
Yes, so like I said, taking the time to do the counseling, finding those situations, offering help, not only in counseling, but also there are nicotine patches that we can do in descending doses, help people get through the effect of that. There are even medications that we can prescribe in pill form that helps tune down that craving for the cigarettes so people won't crave the cigarettes anymore. So there is a lot of help that we can do for people to help them quit, and they will quit way more often if we help provide the support rather than just telling them, you should quit, why don't you quit? Why haven't you quit yet?
So this is something that your practice is really committed to.
Yes.
I mean, like, if people are interested in quitting smoking and maybe haven't had the kind of support that was necessary to help them be successful, maybe they could just say, listen, I want to come to your office and talk about quitting smoking, and they can know, obviously a pulmonologist is going to take this very, very seriously, and we'll go through the time and make sure that they understand, make sure they have the support, and do everything that's possible to help them be successful in quitting. Your office will do that.
Absolutely.
This is a tremendous resource for us to have.
And I can tell you from a personal level, I find it very gratifying when someone comes into the clinic who smoked for years, that we're able to go through the process, and at the end of it, they quit smoking. We enjoy that a lot.
Oh, talk about having an impact on somebody's life.
There's a thing out there, Doc Matta, that is called Chantix.
Chantix.
My brother-in-law got on that. He said he actually lost the desire to smoke very quickly.
Yeah, so that's the medication I was mentioning that kind of
Is
helps.
that a prescription thing?
That is a prescription medication.
Oh, I didn't know that, okay.
And so this is as helpful as the patches, at least from what we know from studies that have been done on it. It's not without side effects, so if we're able to do with counseling and with the patches, that would be our first line.
Mm-hmm.
If that's not successful, then medication like Chantix would be our second line.
Okay.
So there's a lot of different approaches, and it's just a question of what the individual person is going to need.
Yes.
So this is individualized.
Absolutely.
Oh, boy, that's...
And like I
that's
said, the
fantastic.
counseling is just it's basically a conversation from one person to the other about some of the challenges of this task. And because we've seen so many people go through it, we know what helps and what doesn't, and we can put a plan, and then we'll follow up. So we'll give them a call a couple of days, say like, hey, how's it going? Are you doing okay? Do you need help? How do you think things are
Fantastic.
going so far?
That's fantastic. Gosh, that's just wonderful to have that. All right, so a person out there is listening and they say, okay, I get this, and I might be at risk for lung cancer, and so they call your office, and they come in and you go through the process with them and take the time, and you arrive at the conclusion, yes, this is somebody who should be screened. So you get a high-resolution CT scan, okay, and something shows up, small something shows up, okay. What happens next?
So that's a great question. So that's what they call a nodule or a spot, and that depends on the size, and the follow-up depends on the size. So obviously they are high risk because this is why we screen them for. So they need to be followed up at least for a total of 2 years to remain stable for us to say this is not going to grow over time. We don't do it every month, we do it periodically. So we may do it at 3 months, we may do it 1 year, and then we may do it another year. And if they don't change in size, that tells us that they're probably not going to change in size over time, and there's something benign, not cancer.
Because there's a lot of nodules that aren't cancer.
9 out of 10 nodules are not cancer.
9 out of 10 nodules.
So
are not
9 out
cancer.
of 10 times, given everybody, those are not going to be cancerous. So the minority of them may grow over time. And like I said, so follow up with CAT scans, making sure that they stable is one way. Depending on the size, if they're close to 1 centimeter in size, those are more worrisome.
That's about half an inch.
It's about yay big.
Yeah.
And there's more options that you can do for those. There's something called a PET scan. A PET scan is basically similar to the CAT scan that they got in the first place, but they get given an infusion that has glucose in it that's been marked by a tracer. And this sugar goes up in the blood and goes to the cells that are
Active.
multiplying and that are active. And if it goes to that spot, that tells us that this spot is active and getting bigger, and we need to do something about it.
So that's what people hear about when they say something is lighting up on a PET scan.
Lighting up on a PET scan.
Okay, so you can see it. Okay, so you see somebody comes in and they have a nodule, and it's less than a centimeter, and so you get a CT scan 3 months, 6 months, depending, and it hasn't changed. And then the next CT scan hasn't changed. They can be reassured that that's not a malignancy.
That's not a malignancy. Up to 2 years is when the follow-up should be. So if the CAT
Up to
scan
2 years.
2 years from the initial one that we've gotten, and they haven't changed, chances are they're not going to change. The only difference we'll put to that if they have heavy asbestos exposures, those we don't know, so we may push it one more CT a third year out just to be as sure as possible.
Okay, all right, so that's individualized as well.
That's individualized as well. Most of the care is going to depend on the person. The basic rule of what we do is similar, but every person has a little bit different situation. So everything has to be tailored to whatever the person's needs and what they can do and everything else. And we would change whatever we want to do based on what makes sense to them. The plan of care has to make sense to what who the patient thinks and everything else that's
Very,
going on
very
in the
important.
lives.
So they have a chance to discuss it with you.
Absolutely.
And make sure that they understand why you're making the recommendations that you are.
Yes.
And then it's really kind of a joint decision.
It does help a lot when people know why they're doing what they're doing.
Absolutely. That's kind of a general subject that we emphasize over and over and over on these shows, is what we call empowerment. People understanding what's going on so that it makes sense to them, so that they feel and actually do have more control over what's going on in their life.
Absolutely.
All right, so now you got one and it's a centimeter, and so you decide to get a PET scan and it lights up. Now what happens?
So just the fact that it lights up, it doesn't necessarily mean it's cancer.
Okay.
It means it's active, whether that's an infection, and there is histoplasmosis in Ohio, so that's common too, so we see some of those. It could be an inflammation. It could be sometimes a multiple area of things that can be there. It doesn't necessarily have to be cancer, but it means that at least it's multiplying, and we need to figure out what it is.
Okay.
Rather than just watch it grow over time.
Okay.
And those are the ones that we usually go after with biopsies.
Okay.
And there are multiple ways of getting the biopsies. The ones that we usually opt for because we think are the safest are the ones that are done with the bronchoscope. The bronchoscope is basically a camera on the tip of a tube, which is a scope that goes down through the airway. It shows us inside the airway. And then we're able to put out what we call a biopsy forceps, which comes out like an instrument that's able to get bites from parts of the lungs.
What
And
if
we
it's out away from the airways?
We can still get them.
You can still get them through a bronchoscope.
We can still get them
Wow,
from the bronchoscope.
wow,
So it
wow.
gets out from the airway into the tissue, and there are multiple ways to know where we are. So either we have the simple X-ray that's taking pictures, so we're able to see the metallic object, how far out in the lungs, to get the biopsies from those parts. And there's a little bit more advanced technology called electromagnetic navigation, which is similar to a GPS system for the car. It's a GPS system for that instrument that takes it to wherever part of the lung that's in there.
Wow.
We get those bites, we send them to the pathologist, they look at them under the microscope, and they give us the verdict on what they are, and then we decide what we need to do about them.
Fantastic. Now, you do bronchoscopy.
I do bronchoscopy, and we've done a few in Conneaut over the last couple of weeks already.
See, folks, this also, I think, maybe more than anything else, serves to underscore what's going on here, why this is so significant that Dr. Matta has come to this community. We did not have bronchoscopy before he came. We just simply didn't have it. And so if somebody's got to go to Geauga to get a bronchoscopy, or even into Cleveland, well, that's a lot of moving parts, you know. And what do they say? There's many a slip, twixt the cup in the lip. They can get lost. But now we have control of it here in our own town, okay? So if that, and now, we wouldn't do a PET scan here, they'd have to go somewhere else.
Geneva.
They'd have,
Geneva has it on Monday, on Mondays, I think, or
Okay.
every other Monday of the month. But they have them at Geneva available. We've had a couple done at Geneva so far.
So folks, you don't have to drive any farther than Geneva for
Right.
this. Huge benefit to our community. And then if it turns out that it is something that requires a tissue diagnosis and a bronchoscopy, that can now be done here in our hospital. So this is part of, I think underscores part of the UH philosophy, which is to raise the bar throughout the system, to try to bring all the different hospitals within the UH system up, 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 up in terms of the sophistication and the kinds of services that are available to the public. And that is fantastic. That is fantastic that that can be done right here in our hospital. Okay, and so let's just follow this out a little bit further. You do the bronchoscopy. Now, that's not something that's uncomfortable for the patient, is it?
So people would get sedation, so they will be sleeping through the procedure.
Okay,
It's
so
not like the general sedation that they get for surgeries, but they're still comfortable, they're not in any pain.
so it's like an endoscopy.
It's an endoscopy.
Well, a lot of
Same
people,
as an endoscopy.
yeah, people, and and if you ask people what they remember about their colonoscopy, they're going to say, I don't remember
I
anything.
remember the prep from the day before is the answer that I get, that we get more often.
That's for sure. That's for sure. But they're not going to remember the
They're
scope.
not gonna remember the scope itself.
So it's not going to be an unpleasant or painful procedure. They're not even going to remember. They're not even going to be aware of it.
They would not remember a lot of it, yes.
Okay, so they get their bronchoscopy, and now you have the report from the pathologist, and it turns out that that nodule is malignant.
It's malignant.
Okay, this tiny little thing has now been diagnosed. We know it's malignant. So then what happens?
Then it becomes to know what type of the cancer and what the stage of the cancer. The types of cancers are becoming more specified over time, but they're still kind of into two big categories. One is called small cell lung cancer, which is the more aggressive type, and one is called non-small cell, by opposition to the first one, which is a little bit less aggressive.
So let's say that it's not a small cell.
Then it becomes at what stage it is. And for staging, it depends on whether it has spread anywhere else in the rest of the body. That would be the worst situation.
Sure.
And then whether it has spread inside the lung, so the other side of the lung, or to the lymph nodes around the chest.
And that's usually picked up either by PET scan or CT or.
So that's usually by the PET scan, and sometimes we call something called an endobronchial ultrasound, which is called EBUS by short.
Uh-huh.
And that's an ultrasound on the tip of the scope. So we're doing the same endoscopy like we did, the same bronchoscopy like we did. And we're able to look inside the airways, push that ultrasound against the wall of the airway and look for those lymph nodes.
Oh,
and we
my
can
goodness
sample them with a
gracious.
needle, and we see lymphocytes because this is where they live there.
Fantastic.
And we try to see if there are cancer cells in there.
Fantastic. That is just fantastic. Wow. And so we can do endobronchial ultrasound here.
In Conneaut, we cannot do endobronchial ultrasounds. So
Okay.
this technology is not available. So this is a
That's very, very sophisticated stuff.
That's one of the most sophisticated. So in navigation and the endobronchial ultrasounds are available mostly at the main campus.
Okay.
So if it comes to that part, then I'm available on Fridays at the main campus. So we can have someone come in on Friday morning.
Okay, so a patient has you for the doctor and has been through this whole process with you. They know that you know them, that you know the situation, you know what's going on. So if it gets to the point where they have to go, and obviously they would in a situation like this because it's so important, okay, that they would be willing, and they go to main campus, they're not going to lose you as.
They're not going to have to go through the same whole process with another doctor, and some information may be missed, and they get to tell everybody the same story all over again.
That's
At least
important.
there will be.
Oh
That's
my
very
gosh.
important.
This is fantastic.
Because
I'm learning a lot here, folks.
This
is-
happened when we have a patient and they would say, okay, so one, people would not want to leave Conneaut. This is my experience so far. If they don't have to go any further, they don't want to go any further.
Well,
And
sure.
that's very understandable, and that's what we thought in the beginning, because people don't want to be taken out of their elements and put it somewhere else where they don't feel comfortable or they don't know the
Have to
people.
make a long drive.
Have to make a long drive with the bad weather and everything else. So that's the first part. I think they're a little bit more willing to do it if they know at least they're not going to have to go through the whole process with a whole new doctor. So when that happened, they said who's going to be the new doctor they're going to see. And if you are the person they already know, you already established that relationship with them, it makes it so much easier for them than to have to go through the whole process again.
Oh, gosh, absolutely. All right, so then they go through this, and it turns out that there's no evidence that it's spread anywhere else. It's malignant, but it's been found early enough that it hasn't really gone anywhere, which is like a very big deal if it's all.
Yes.
Okay, so what will happen then?
We have to take it out.
Okay.
Surgery is the ideal treatment for any cancer, and including lung cancer, is if we're able to resect it. Those cancer cells are no good. They need to be taken out of your body before they do more damage and before they make nests for themselves somewhere else in the body.
So if there's no evidence that they're anywhere else, and we're really confident that it's just right here, if it's gone, it's gone.
If it's gone, it's gone. We've watched people over time just to make sure that there was no
Sure.
hidden cells somewhere, but that's a cure.
That's a cure.
We're treating it, that's a cure.
And that is something that Dr. Argoti Green can do over in Geauga.
Absolutely.
So again, this is something where you would not have to go to Cleveland. You would not have to go to main campus. And once that's done, like you say, of course, they're going to be followed, but the whole process has taken place pretty much right locally.
Absolutely.
All right, so boy, I mean, this is really amazing. I didn't realize that we had that kind of depth to what we can offer here. That's fantastic.
I think we can do the vast majority of whatever needs to be done without having people leave Conneaut at all. Like all the pulmonary function testing that we need, 6-minute walk tests that we have people do in anticipation if they ever need surgery, what their function is, what their lung function is, all those we're able to do here. People who need to get stronger, we have a pulmonary rehab program. So we have them go through rehab, get them as strong as they can be. We can do all the testing, we can do the bronchoscopy, we can do almost everything up to a point. And if that point needs to be crossed on a small portion of people that we end up seeing, then we have the capacity of doing this at a bigger place than here, which would be either Geauga or the main campus. And this way we will save people all those unnecessary trips that can be taken care of right here.
Exactly, because as you point out, it's going to be a very small minority of patients.
Absolutely.
Who actually need the greater depth
The greater depth.
and so on. Wow, that's really, well, I mean, you know, as we started the show by saying that this represents a major change in the level of care that's available here in our town, people, I think, are starting to get the idea of what that actually means. Well, that's terrific. Now, obviously, there's a lot of other things that you do, a lot of other clinical problems that you do, and I'm hoping that you may be able to find time in your schedule to come back and visit with us again to cover some of those problems.
I would love to. I think there's a lot of topics like COPD and pulmonary rehab and asthma that interest people that would like to learn more about, so we can allocate another time and spot and try to provide information about and counseling about those issues.
Oh, that's terrific. Well, we will be definitely hoping to have Dr. Matta come back maybe in February, end of January or February, and talk about some of these other issues, because there is a lot in these that I think will be very beneficial for people in our town to know about. Don't you think so, Pat?
Absolutely, and like Dr. Matta just said, asthma, COPD, very, very common in this area.
Very common.
Yeah, so
Very
I think
common.
that would be interesting to
It'd be
tackle.
interesting. I think it'd be very, very helpful for the public.
Sure, sure.
Well, we really appreciate you taking the time to come by today, and we're so happy to have you as part of our medical center here at Conneaut. Thank you so much for coming.
My pleasure. Thanks a lot for having me.
Okay.
All right, that's another edition of Your Health Matters. We'll see you in another week.